You can hear me okay?
Yeah, we can hear you. We can see you.
Good, good.
All right. Well, we're up. We're excited to have you participate, be a part of this. And Frank is going to talk a little bit about some other optical treatments and share his great experience with us. We appreciate it, Frank. Thanks.
Okay. Well, I think I've done quite well here in the UK. The timings have worked out well for me. I have been hearing about what time it is in Australia, and I don't know what time it is on the West Coast. I don't know if anyone's over there. You're not over there, Avery, are you?
No, no, no.
But
I am.
it's mid-afternoon here. We have a clinic running at the minute, so it's only me that was available, I'm afraid. But some of you will be familiar with this talk as well. Rebecca gave you a lot of the information from this talk on the Nystagmus Network Day for those of you that were there. So I'm going to talk about optical treatment options, and I want to tell you in particular about a randomized controlled trial that we have recently completed on contact lens wearing. So why treat infantile nystagmus? And one of the things that we've been interested in Leicester is quality of life in infantile nystagmus, and this is the work of Rebecca McLean mainly, and she found that when she performed interviews on individuals with nystagmus, that in these interviews a substantial number of the patients wept. 10 of the 21 participants wept, and for them cosmesis was a major issue. So in terms of treating nystagmus, we're not just thinking, of course, about treating visual function, but also the social and psychological domains of life. And as I'm sure we'll hear over the next hour or so, there are the main treatments that are available are pharmacological treatment, gabapentin and memantine. Avery's mentioned these things. Where hopefully we will have completed a large crossover trial on these two drugs, gabapentin and memantine. The last patient will be completed by March, so we await the results of that trial. Certainly the responses that we got from the first trial were quite variable, and we're interested in which patients respond primarily in looking at that trial. That's why we've performed a crossover trial. And we're going to hear about some of the surgical treatments in the next talks. But this is an observation that Rich made that in one of the publications, I forget which one it was now, but that in terms of a treatment, refractive correction is perhaps the most effective treatment. It is a treatment that can improve the vision by a number of lines, and if we had a pharmacological or surgical treatment that was as effective as refractive correction, we would be heralding it as a wonder treatment, I'm sure. But because of the significant refractive error in these patients, to correct the refractive error is very important. So there's been a number of studies that have looked at contact lens treatment in nystagmus, and most of them report a beneficial effect from wearing contact lenses. The suggested mechanisms are that, first of all, that the contact lens will actually move with the eye, and so the refraction is better as a result of that. But also, it has been suggested that there may be an enhancement of feedback through the eyelids of the nystagmus, and that the patients actually reduce their nystagmus, control their nystagmus through that feedback. However, the results of these studies are variable. The visual acuity and eye movement results are both variable. This is a summary of those studies, and many of them have small sample sizes. There was one study, a retrospective study, with a large sample size on hard lenses, 112, but the eye movements were difficult to interpret. And in general, the results reported are quite variable. There have been no randomized controlled trials investigating contact lens wear in nystagmus, and there has been no direct comparison between rigid gas permeable lenses and soft contact lenses. So that was the primary aim of the study. And what we were particularly interested in was this idea of feedback changing the nystagmus. And our main hypothesis really was that the rigid gas permeable lenses, because they are solid lenses and because they give a greater feedback, that they reduce the nystagmus more than soft contact lens wearing. So this was our trial design. We had a baseline period of glasses wearing where the patients were optimally refracted. Then they had their first phase of contact lens wearing, which was randomized, and then the second phase of contact lens wearing, and then a glasses wearing phase, again, a baseline period. The primary outcome measure was eye movement recordings, and we do favor, of course, a lot of the discussion has been about looking at the foveation period, and we do favor measuring the foveation period. But in this particular situation, because we were interested in the feedback that the contact lenses give, we used intensity as our primary measurement because it's really the fast movements that give the greater feedback. We also were interested in the visual outcomes as well, and we, as we do with most of our trials, we take a broad brush approach to looking at visual outcomes. So we have visual acuity, we have a reading test, the Radner reading test. We use the gaze-dependent visual acuity measurements that Rich and his group have developed, and we also look at subjective changes as well. For those of you that are not familiar with the Radner reading test, the way that it works is you read a series of fonts. It's very similar to the MN read, if you're familiar with that. You read a series of paragraphs where the font reduces in size, and you plot the reading speed, and you can take a number of parameters, such as the reading acuity and the maximum reading speed from this test. And I think as a functional test, it's a very simple but effective test. It's one of our lines of work has been to look, research has been to look at reading in nystagmus, and I do think it's a very effective test, the Radner reading test. This is the gaze-dependent visual acuity measurements that Rich and his group have developed that we use in most of our studies now. And for our eye movement recordings, this is our setup. We have a rear projection screen for the distance. I use the term distance. It's 1.2 meters to get the range of visual angles that we're interested in, and we compare that to a monitor that's at 0.4 meters to look at near viewing as well. And what we do is the main outcome that we look at is the change in nystagmus across the horizontal axis from 30 degrees on the left to 30 degrees on the right, with 3-degree intervals, and we end up with these curves that have been described before by Lou and others. I think one of the things that we do is possibly record more points than in some of the previous studies, and we from our eye movement recordings we derive the amplitude, frequency, intensity, and we also take the NAFX predicted visual acuity measurement as well. We take a measurement from the null by taking an average of the 5 points where the intensity or the NAFX is at its lowest. Really, it's equivalent to applying a 5-point smooth across the curve, and then taking the minimum point. So you can see, if you look at these curves, there is some jitter on them. So it's really to deal with that jitter. Our analysis was an intention to treat analysis, and we used the a last observation carried forward method to account for our missing data, and we use linear mixed models for both eye movement and visual function parameters. We included in the study 12 idiopathic unassociated patients and 12 patients with albinism. For the sake of the eye movement outcomes, we treated them as one group, but for the visual acuity, we distinguished between the two groups because of the big difference in visual acuity with albinism. And so for our primary outcome, which was the nystagmus intensity at the null region, we found virtually no difference between the two main treatments, the contact lens treatments, and then we also looked at the difference between the two treatments and baseline spectacle wearing, and we also found no difference between the contact lens treatment and spectacle wearing. When we looked at the visual outcomes, we did find that there was a difference, a significant difference. So this is the visual acuity measurements that you can see here, soft contact lens wearing on the left, rigid gas permeable lenses in the middle, and spectacles on the right. And what you can see is that in general, that when the soft contact lens wearing takes place in albinism and idiopathic patients for near and distance, the visual acuity is higher. This is logMAR visual acuity, so it's worse with soft contact lens wearing. Please notice the scale here on the left that we are talking about small differences. This is one logMAR line that you can see here, but these were significant differences. And a similar pattern was observed with the reading test as well, the soft contact lens wearing, as you can see on the left here, and here for a number of different parameters, reading acuity and maximum reading speed and critical print size were significantly worse with the soft contact lens wearing. We didn't find any difference for the gaze-dependent visual acuity measurements, and we looked at a number of different parameters. We looked at the average across all of the positions, and we also looked at, well, what would be the equivalent of the longest foveation domain, the width of the null, really. And we found no differences in subjective improvements, either soft contact lens, during soft contact lens wearing, patients reported 30% of patients reported an improvement compared to 40% during rigid gas permeable lens wearing, and for nystagmus, 35% of patients reported an improvement in nystagmus during rigid gas permeable lens wearing compared to 15%, although this was not significant, and we didn't see the equivalent with eye movement recordings. The side effects of contact lens wearing are quite well documented, but one of the things to notice in particular in relation to nystagmus is that with soft contact lens wearing, a number of patients reported movement of the lenses. 7 patients reported a movement of the lens. And in terms of ease of handling, the patients generally reported that rigid gas permeable lenses were easier to handle than soft contact lenses. So the question that we had was, why did the vision deteriorate with the soft contact lenses compared to rigid gas permeable lenses? With rigid gas permeable lens, there is it has a spherical rear surface that is filled with tears that neutralize the astigmatism, whereas for soft contact lenses, the lenses are toric, and the lenses need to be aligned correctly to correct for the astigmatism. And so what we did was we took one of the soft toric lenses and we marked it, as you can see here, and we monitored the change in the position of the lens with time. And what you can hopefully see on the picture here is over time, over the course of a minute, you can see a misalignment of the lens taking place. And overall, however, we did look at the relationship between the amount of astigmatism and the decrease in visual acuity, and overall we found that there was no significant relationship between the two. So there are a number of factors that perhaps could affect the orientation of the lenses, the eyelid anatomy, blinks, change in direction of gaze, the fitting relationship between the lens in the eye and the lens in the eyelid, and gravity itself. And sorry, that figure hasn't come out correctly. It had some arrows and so on there. But our idea is that because these lenses are weighted, that during the quick phase there is a vector of force because gravity will pull the lens downwards. But as if there's a quick phase in the left direction, say here, then the inertia of that weight will rotate the lens, the bottom of the lens, if it's being pulled down to the right, and will twist the lens. It will become misaligned. So in summary, we find no significant difference in eye movements with these two types of lenses, but we found that the visual function was significantly worse with soft contact lens wear, although the difference was less than 1 logMAR line visual acuity, and one could argue that it's not a clinically significant difference. I think one thing I would say in relation to that is that we are talking about a spectrum of patients here. This is the overall trend, and so it might be worse in some patients. And we found subjectively that there were no significant differences either. So I think currently what we would recommend is to go with rigid gas permeable lens wear. I'd welcome any discussion on this, of course. There are those that would know much more about contact lenses than I do. I'm not a clinician. I'm a basic scientist, so I would welcome a discussion on this. But I think what our study raises is just some caution in relation to soft contact lens wear, and for appropriate fitting of soft contact lens wear. We do think that there are situations where soft contact lens wear would be more important, such as in contact sports. But we are recommending that in the first instance that rigid gas permeable lenses should be prescribed. Thank you. Contact lens wear would be more important.
Frank, thank you very much. As always, excellent science. And this is why it's important, I think, to do clinical trials, because our anecdotal experience, those of us who care for these patients and see them, and I encourage the use of contact lenses because I think the qualitative improvement in visual function seems to be at least reported to me by the patients. And we're trying to tease out what is it about going from spectacles to contact lenses in this population of patients that seems to make them feel better about their vision. I think it's very important. I'm not sure what that is, but these kinds of studies are really helping us out and helping us understand how maybe to use contact lenses better and what to expect in them. So I really encourage this kind of work. And this is the only way to really to get evidence to prescribe them or not. But it is, as we've discussed before, especially at the NN meeting, it's surprising sometimes because, having seen hundreds and hundreds of these patients, they all love their contacts. It's that's what got me interested in this as well. They say, I function, I see so much better. So we must not be studying the things that we think are making them better. Maybe it's not the nystagmus waveform. Maybe it's not gaze-dependent visual acuity. I don't know what it is. And so this maybe will help us understand it. Does anybody on the panel have anything to say, or from the audience?
Yeah, Rich, it's David out in San Diego. Frank, there was something that you mentioned early in your talk that I don't want to let slide by, and that was the patients weeping, and the cosmetic effect of this. And I gave an anecdotal example of one of my patients who felt so much better about herself and had so much more confidence. And the number of people that we hear anecdotally that after their waveform changes or their nystagmus is visibly lessened, that they feel better about themselves. I think that's it's similar to an editorial I wrote in the British Journal of Ophthalmology about the cosmetic impact of strabismus surgery. And call it cosmetic is almost doing it a disservice. It's a psychosocial impact. And I think that I'm really pleased that you mentioned that, and I didn't want that to go by too quickly.
Okay, thank you for that. I mean, I think it's important to try to capture that in the clinical trials, that we try to capture the effect of our treatment options on cosmesis. And, it's one of the things that we're trying to develop at the moment is a questionnaire that actually does that. But I think you're right. There is so much more than just visual acuity measurement in relation to looking at the effect of the treatment options that we have.
Do you think, may I participate to this discussion? Can
Sure.
you hear me?
Sure.
Yeah.
Okay. Do you think that the proprioception with rigid contact lenses could be the cause for the better result in visual acuity? I mean, the proprioception of the movement.
Well, I think that was the main reason we looked at the study. There's the idea that proprioception influences nystagmus. That comes from the tenotomy work. So I think we were expecting more, to be honest, in terms of the eye movement. But in terms of both nystagmus intensity and foveation, when we used the NAFX measurements, we found no difference. It was very flat. And so we don't see any evidence for the contact lenses changing the eye movements through proprioception. It may be that we've missed something. We only had 24 subjects in this, but certainly from what I could see, I didn't see any differences in the eye movements through
Can
contact
I
lens.
have also the opinion of Lou Delos on this? Because he studied this aspect.
Yeah. I'd be interested as well.
Yeah.
The thing I would ask is, did you look at their gaze angle curve before and after? You're not going to get any increase if they are pretty broad to start with. My experience with contact lenses is they're great with sports, and that's the only time I use them. My glasses are much better because I'm using convergence, and convergence is the best. But that aside, the curves I got were that the peak acuity didn't change much at all from glasses. But what changed was the peak acuity to the left and to the right was almost the same. So that's where you get your improvement. So some of your patients might have had broad curves to start with, and you can't expect much. You just have to look at the ones that have sharp ones, sharp peaks, and did they improve out at lateral gaze angles?
We went and looked at the data, and we did the longest foveation domain on all of the eye movements. The reviewers requested it in the paper, so we went and did that, and we didn't find any significant difference. I think I corresponded with you about this, Lou. But one of the issues was that I felt that the measurements were being distorted, perhaps by one or two individuals where a lot of the data was close to the 90% threshold, and what we were finding was big differences from those individuals that were perhaps contaminating the rest of the data. So we didn't find anything that was significant, but I don't know, it maybe needs a little bit more investigation.
Dongshang and I have recorded, we'll do this occasionally. I don't think we've ever put it together in a paper yet, but I've had patients and I've in the lab, in the office, and I record them immediately with and without their contacts, and we can see, so I have patients that have a dramatic difference in their nystagmus. I know there's some. That it may be an ideal population. There may be something unique about that population.
Okay.
But I have seen physiologic changes immediately. Now, that also may be the thing. Maybe it's the immediacy of the contact lens that stimulates the proprioception, and then there's a down regulation of the effect of contacts as opposed to surgery or topical medications, which is why we have to redosing. So it may be the timing at which the contact lens is placed,
Yeah, we didn't, I mean, that's true. We didn't actually measure the eye movements just immediately after the contact lens was fitted. Are these patients that are used to wearing lenses, or?
Yeah, some of them have worn them
for the first time.
Yeah, and some of them wore them. Some have are recent wearers, but most of the ones that come from out of town with their lenses in, and I say record them without and record them with.
Yeah.
And so most of them are actually at least minimally experienced contact lens wearers. So there must be something about the immediacy of this that makes a difference. And I hadn't thought about it again until I heard your paper again here. I wonder.
There's also a little screening test you can do. If you just scratch their head above their eye and stimulate the ophthalmic division, if you can see a change in the nystagmus, then that bodes well for lenses working. If you don't see it, then they're probably not going to work, because that's the pathway.
Okay, that's interesting.
So I mean, it's so sensitive that I've even noted on windy days I could play the outfield, but on calm days I have to play the infield. So even the wind on my forehead is enough.
Okay.
You may have noticed that we have paper that talking about the stimulate on the tongue reduce the nystagmus, but those nystagmus from patient they are blinded. But lately we have some new observation, bite on the tongue reduce nystagmus. We see a significant effect.
Okay. Okay.
I think for the sake of time, we do have a bunch of questions that came in, but I don't think we're going to be able to get to those right now. We might be able to get to them later on. But for the sake of time, we're going to move forward. And our next talk is going to be the surgical options